Hello, everyone. Very good morning and welcome to this master class where my colleague Dr. Anand Shukla from UN Mehta is a professor in the UN Mehta Ahmedabad is joining us to moderate this session. And basically, this is a case discussion of a multivalvular heart disease where Dr. Sandeepan Saha, who is a third-year resident at our institute, is going to present the case. And we will discuss about this case as we do in the day-to-day clinical case discussion scenario. And this will be very helpful for the exam going students in the DM or DNB, where it is a common case which is given to them and discussion on this important case. So I will request Dr. Sandeepan Shah to start the presentation. And Dr. Anand, please check whether your audio is okay or your mic is okay. Still, we are not able to hear you. Anand?
Anand sir, can you hear us?
Anand? Are you able to hear us?
No, actually, no, sir, can kindly leave the meeting and join again. Maybe it may help you to pick up the audio.
So we are waiting for the Dr. Anand to join. So then we'll start the presentation and discussion. I think there's some technical.
He's joined back.
Right.
Sudeep sir, can you hear me?
Yeah, now it's loud and clear.
Okay, thank you.
Right.
Please start.
Right.
Please.
All right. Sandeepan, you can start now.
Yes, sir. Yes, sir. Good morning, everyone. Today, I'm presenting a clinical case presentation on a case of multivalvular heart disease. So my patient, who is a 14 years old male, hailing from Prayagraj, Uttar Pradesh, presented to us with the chief complaints of breathlessness for the last 1 year, on and off palpitation for the last 1 year, and swelling of bilateral lower limbs since last 1 month. The patient is a 14 years old male, student of class 6, Hindu by religion, and the informer is the patient himself. On elaborating the history of present illness, the patient was relatively asymptomatic before 1 year of age when he developed exertional breathlessness, which was insidious in onset and progressive in nature and non-seasonal. Initially, he was able to carry out his day-to-day activities and felt breathless only on playing school games. And over the period of time since 2 months, he has developed breathlessness on doing household activities like dressing, undressing, taking bath, and climbing 1 flight of stairs, suggestive of NYHA class 3. He also gives the history of dyspnea on recumbent position.
Can we interrupt here?
Yes.
So why do you say it is NYHA class 3?
Sir, the patient has developed dyspnea on which is less than ordinary physical activity. So it is NYHA class 3, sir.
So according to you, that patient's ordinary activity is limited.
Yes, sir.
So he is symptomatic in the day-to-day household activity. What do you mean by the household activity? Meaning?
So day-to-day activities like dressing, undressing, and like getting up from bed, taking bath, or climbing 1 flight of stairs, which he did not have previously before the onset of these symptoms. Initially, he used to have symptoms only on playing school games and all. So now he has developed
So why it is not class 4?
Sir, class 4 is the patient is unable to carry out any physical activity without discomfort. So the discomfort is present at rest as well. But in this patient, the patient did not have discomfort at rest.
Just a minute, just a second. So the
Yes.
definition of class 4, is it mandatory to have symptom at rest?
Sir, class 4 definition is unable to carry out any physical activity without discomfort.
So that's how we are going to differentiate whether it's a class 3 or class 4. So do you believe that he's able to do some activity without any symptoms, and that's how
Yes,
you okay, all right. So what other activity scale or functional class do you know of?
Sir, apart from NYHA, there is the Goldman specific activity scale, where we calculate the METs achieved by the person. We also have the visual analog scale, which is a pictorial representation of how the patient perceives dyspnea. In pediatric patients, we have the Pavlov classification and also the Minnesota classification. And apart from NYHA, also have the WHA classification and the Goldman, modified MRC scale.
So WJ classification is used for which group of the patient?
Sir, pulmonary
for all
hypertension.
the patient. And what the Canadian cardiovascular scale?
It's mainly for angina, sir.
It is being used mainly for the angina, but it's meant for all the activities. So why NYHA classification is so important for us? Sir, why we are most commonly using the NYHA classification?
It is the simplest classification that can be produced by any layman patient, and it is easy to interpret. So
what are the shortcomings of this NYHA function class?
So shortcomings are it does not take into account the aggravating and the relieving factors. It does not take into account the history of orthopnea and PND. It does not take into account the history of treatment which was given to the patient, and also
so
there is huge
is included. Say it, and orthopnea you can consider as a class 4 because he's symptomatic at rest.
Yes, sir.
All right.
And also there is huge intra-observer variability.
So one is it is simplest to use. What else? Why it is important from the patient perspective?
So the activity which are assigned in this classification are the ones that can be reproduced by the patient at any time. So it is easier to use, sir.
Yeah.
The important thing that it can be applied because laborer person have ordinary activity different class grade and office work. So that's why we can uniformly apply.
Yes, sir.
That is one of the advantage. I cannot apply in the pediatric and the pregnant woman.
Yes, sir.
Yeah.
So it's a subjective. That is the beauty of the NYHA classification. For any individual patient, it is subjective, and that is the drawback also, that it is not objective. Okay, go ahead.
He also gives the history of dyspnea on recumbent position, which is relieved after assuming sitting position. He also gives history of one episode of nocturnal episode dyspnea, 2 to 3 hours after going to bed.
What is recumbent position? What do you mean by this? What is the type of dyspnea it is?
It is orthopnea.
Orthopnea. It is present always, or it was?
It was present previously around 2 months back, but now with the help of some treatment, he has relief of orthopnea.
So one is orthopnea. And do you know what is bendopnea?
Yes, sir. Dyspnea on bending forward, bendopnea.
And what is tripopnea?
Tripopnea is dyspnea on lateral position.
So which is specific for cardiac diseases, tripopnea or bendopnea?
Sir, bendopnea.
So is it what is the difference? What is the prognosis between the bendopnea and the PND?
Sir, PND, although not classified under any stage, but it is considered in the class 3 of NYHA. And bendopnea is also not classified, but also it is a severe form of heart failure, so it can be classified under class 4.
Yeah, usually bendopnea, they have a very elevated LV LA pressure. So these patients are more symptomatic. All right, so you can go ahead.
He also gives history of one episode of nocturnal episode of dyspnea, 2 to 3 hours after going to sleep, and he used to sit upright and roam before returning to bed again. The nocturnal episodes of dyspnea was associated with cough, which was occasionally associated with blood-stained sputum.
So what is the interpretation of this history?
Sir, this is one episode of PND, sir.
Okay. So why do you say it is a PND? Why not it's orthopnea? Because patient is also having orthopnea.
Sir, in orthopnea, the dyspnea occurs immediately after assuming recumbent position, while in PND, the orthopnea occurs about 2 to 3 hours after going to sleep. So it does not occur immediately on recumbent position. So PND is different.
So according to history, the patient was having orthopnea. Then he had one episode of PND. Is it possible?
No, sir. He first had one episode of PND, followed by orthopnea.
Right. So what does this signify?
Sir, it signifies severe pulmonary venous hypertension.
Meaning there was a disease progression.
Yes, sir.
So what is the mechanism of PND? This is often asked question. And
sir, PND, there are various mechanisms. One is on assuming recumbent position, there is slow extravasation of fluid from the extravascular to the intravascular compartment. So the extravasation is slow, so it takes some time. That is why PND occurs late. Second is there is decreased adrenergic drive during sleep, which causes this dyspnea. Third is there can be depression of the respiratory centers, which causes increased breathing effort. And then some risks like transient nocturnal arrhythmias can also cause PNDs.
Yeah, there are various proposed theory, but most logical theory, which is the most logical theory and
decreased adrenergic drive.
Yeah, that is a decreased adrenergic drive. Rest can be explained by the orthopnea. Rest can be present in the orthopnea also. Go ahead.
The patient also complains of intermittent palpitation for the last 1 year, which is perceived as a thumping sensation in the chest. It was gradually in onset, gradually in offset. It is increased with exertion and recumbency and relieved with rest.
So what is the type of these palpitation?
So this is a volume overload.
Arrhythmic or not arrhythmic?
Not arrhythmic.
Okay. The slow onset and slow offset can be present in some form of arrhythmia. What are those type of arrhythmia?
Sir, atrial fibrillation.
Yeah, atrial fibrillation. Yeah, go ahead.
He also gives a history of swelling of bilateral lower limbs since last 1 month, which was insidious in onset and progressive in nature. The swelling of the bilateral lower limbs was followed by swelling of face. However, there was no history of decreased urine output, yellowish discoloration of skin and urine, or abdominal distension.
For edema history, you have to give the diurnal variation, whether it's more often late evening or more early morning, or get relief in the early morning. Because the differential diagnosis of edema, we come first the right sided heart failure versus renal versus hepatic. So the diurnal variation and relief by the supine, that should be included in your history presentation.
Yeah. Yes, sir.
Please.
There is no history of chest pain, giddiness, or syncope. There is no history of bluish discoloration of skin and mucous membrane. There is no history of recurrent LRTI in childhood. There is no history of any drug abuse or any bleeding diathesis. Past history.
Please go back. So what is the relevance of taking history of drug abuse and bleeding diathesis?
Sir, since the patient had one episode of hemoptysis, not 1, 2, 3 episodes of hemoptysis, so bleeding disorders can be considered as the cause of those symptoms. Further, there are some valvular heart disease that can be associated with bleeding disorders like aortic stenosis. And
which type of aortic stenosis is associated with the bleeding disorder?
Valvular.
Is it
where bleeding occurs?
Yes, sir.
It is a degenerative aortic stenosis.
Yes.
That lead to capillary telangiectasis in the large colon and the blood per rectum.
Yes, sir. Haiti syndrome.
So please continue. And chest pain, giddiness, pre-syncope. No history. Okay. Next.
The patient gives a definite history of prolonged fever with joint pain 2 years back. The joint pain was fleeting in nature. It mainly involved the large joint, mainly the knee and the ankle joints were involved. It was not associated with any skin lesion or abnormal body movements. The joint pain subsided with some medication, which he could not specify. However, there was no history of penicillin prophylaxis.
And
What
so
do you-
how will you
Yeah.
elicit the history of the joint pain, relevant rheumatic fever history? First, you have to elicit whether is a family member affected by the same, and whether belong to lower socioeconomic status. So can the cross infection are the much more frequent.
Yes.
Whether patient is living the hostel premises or the close congestion. These are the factors. Though the low social status has been not proven for the acute rheumatic fever, but residing in the small space, a larger number of population, either military bases, hostels, they are, or low social status where the large number of family were residing in the small.
Yes.
And regarding the prolonged fever, if suppose patient has not taken any treatment, this prolonged fever will acute rheumatic will subside or joint pain will subside or not?
It will subside, sir.
Okay. Sudeep sir,
In
you want to ask
what is the time frame of the joint pain to subside?
Sir, it usually subsides in 2 to 3 weeks. Or if it does not subside in a span of 1 month, then alternative diagnosis should be considered.
Usually takes 4 to 6 weeks, not 2 to 3 weeks. So, what is the type of arthritis in this patient?
Sir, the type of arthritis is large peripheral joints are involved, which are asymmetrical, migratory, and non-erosive and non-deforming.
So, can you label this episode as a patient of rheumatic, acute rheumatic fever?
Yes, sir. The patient has one migratory polyarthralgia. So this can be taken into consideration as a major criteria. And also,
how will you elicit the history of arthralgia versus polyarthritis?
so arthralgia is pain without swelling.
Pain, tenderness, and swelling, all three components.
Yes, sir.
Please continue.
So, is it not a PSRI? Why do you
Sir,
label this?
In PSRA, it occurs after same streptococcal infection, but also the smaller joints are involved. It has got a very short latent period, and the smaller joints are involved, and it does not respond promptly to salicylates.
So you don't have any history of therapy in this patient, whether this patient received any aspirin or steroid?
Yes, sir. But over-the-counter medications, because rheumatic polyarthritis responds promptly to NSAIDs, so the patient might have taken NSAIDs due to which the joint pain has subsided instantaneously. Had it been a case of PSRA, it would not have been subsided spontaneously.
So, what is the differential diagnosis of migratory arthritis?
So, migratory arthritis, first is acute rheumatic fever. Second is some viral arthritis. Third is SLE, polyarthritis nodosa. Then meningococcemia, Neisseria infections like Neisseria gonococcus or Neisseria meningitis can also cause migratory polyarthritis. And also in Whipple's disease.
Sometimes in leukemia. So what is very, very peculiar about the acute rheumatic arthritis?
Rheumatic arthritis is large peripheral joints, asymmetrical, migratory, non-erosive, and non-deforming. It responds promptly to salicylates or NSAIDs.
And what is the relation between the effusion and pain in this type of arthritis?
Sorry, sir.
The quantity of pain versus effusion.
Yes, sir. The pain is it's not proportional to the amount of effusion. The pain is very high compared to the effusion.
So if the patient is having pain more than the effusion, out of proportion pain, so what are the differential diagnosis? Like one is acute rheumatic fever.
Yes, sir.
Suppose the patient present early with one joint involvement, large joint involvement. Now the pain is very much and the effusion is less. So what differential diagnosis will come to your mind?
Sir, viral arthritis.
Yeah.
Then also PSRA.
Maybe the pain is not so great. And then acute leukemia and an HIV.
Yes, sir.
What relation of polyarthritis and carditis and acute rheumatic fever, whether they proportionally, inversely proportionally related?
Sir, carditis with polyarthritis is seen in about 50% of patients.
Suppose there is no recurrence of joint pain as per your history.
No, sir, no recurrence of joint.
So just we briefly discuss it about the mechanism of rheumatic fever. So the why patient only as the history wise the one history of the polyarthritis and develop valvular lesion. What is the proposed mechanism for the subsequent valve damage after the episode of acute rheumatic fever?
So it is mainly due to cross-reactivity of the cross-reactivity of against the antigen of group A beta hemolytic streptococci, due to which the antigen attacks the antibody on the myocardial cells. So the patient can have valvulitis secondary to that.
It's acute rheumatic fever is associated with myocarditis.
Very rarely, sir.
We don't see category no, because there is a study, there is no troponin elevation acute. It is a pancarditis, but myocarditis is less, but troponin is less elevated.
Yeah, Pap segment, troponin elevation, and everything has been recent. There is no myocarditis. It's a valvulitis which led to the heart failure.
Yes.
Although we say that it's a pancarditis, the shop nodule doesn't contain any myocardial cells.
Yes.
Okay, go ahead.
Birth history: the patient was born out of non-consanguineous marriage with full-term normal hospital delivery and cried immediately after birth and is vaccinated for his age. Personal history: appetite is normal, bladder bowel habits are normal, and the patient is a vegetarian by diet, no drug allergy. Family history: the patient has 4 siblings and is 4th in birth order. Other siblings are apparently healthy. He lives with his parents and siblings in a Pakka house with 2 rooms and belongs to a low socioeconomic status. Drug history: he is on some drugs prescribed by a local physician, which causes increased urination, following which his dyspnea and bile edema has resolved.
So, any history of IM injection?
No, sir.
So he was never prescribed any benzathine penicillin?
No, sir.
Okay. And the patient was, you suspected that patient had an episode of acute rheumatic fever, and
yes,
still
sir.
he was not prescribed about benzathine penicillin. Whether this patient contacted any physician during that episode of migratory polyarthritis?
Sir, he contacted a local physician in a primary healthcare center. He prescribed some drugs, but the patient did not follow up to the person because his arthritis had dissolved. So after that, he did not take any consult.
Okay.
So I believe that your history part you presented.
Should I summarize?
No, just what is the art of taking history? So once we take the history, there is in our mind some disease will be there. So as per your history, some disease you have thought of.
Yes,
and
sir.
regarding negative history, you have to give the different etiology, negative history of different etiology in your history and complication of that disease in your history, because the negative history is too much short for long case. You said you just rule out the other cardinal symptom of cardiac disease, but you have not rule out the complication what you have thought of from your history. That
Yes,
is lacking. So the long case, it is just you have to present a story. So you have prepared very well symptomatology, chronology, that very well. But once you thought of pulmonary disease producing some pulmonary venous hypertension with the volume overload, you have to give the different negative history of etiology of that disease as well as the complication of that disease. That is okay.
So can you elaborate further on the negative history? Dr. Anand has pointed out very valid point. Can you go back to the negative history and come out with few other points which you may not have written here?
Sir, about the complications, the patient can have infective endocarditis, so his fever should be ruled out.
What was present in your patient and what was not there in your patient, and have you taken the history?
Sir, we need to take the history of any history of CVA, like the patient can have a thromboembolic episode.
Yes.
The patient any history of arrhythmia.
Yes. So you have thromboembolic episode as a prolonged fever of infective endocarditis.
Yes, sir. Prolonged fever of infective endocarditis.
The certain even what you think of differential etiology differential diagnosis, as already Dr. Sudeep sir has mentioned in out the differential diagnosis of joint pain and fever. What are the other than rheumatic valvular etiology will be there? You have to give the negative history of that etiology also. So yes, rule out the patient does not history of any degenerative or renal failure, because the Paget's disease, degenerative calcified disease, all we have to rule out one by one, and connective tissue disorder. No history of skin lesion and joint pain. But that one by one you have to mention.
Yes, sir.
Yeah, please summarize your history and we will discuss the differential diagnosis from the history.
This is my summary. A 14-year-old male with gradually progressive dyspnea since last 1 year, with history of orthopnea and PND and volume overload type of palpitation and pedal edema, with history suggestive of acute rheumatic fever in past.
Also, you can say the boy, young boy, Didika, you either we can summarize it by decade wise or the children, boy, adolescent with such way. May get present progressive dyspnea over the 1 year with history of PND in orthopnea with feature suggestive of the right-sided failure. It recently developed for the 1 month with supported by the past history suggestive of the rheumatic fever in form of polyarthritis or arthralgia. So what are the disease? What are the cardiac disease that are present in the second decades of life? Now, what are the cardiac disease among those cardiac disease having the cardinal symptoms of dyspnea?
Yes, sir.
Yes.
Sir, first possibility is it's a rheumatic heart disease. The pathophysiology behind the summary is the patient has got a left-sided regurgitant lesion. However, the possibility of a left inflow obstruction cannot be ruled out, with history of PVH and RV dysfunction. So the first possibility is a rheumatic heart disease, could be a with valvular regurgitation, left-sided regurgitation, could be a MR or a AR or a combination of both.
Yes, you have to keep the priority. If you present the dyspnea as the first, so whether MS will have first dyspnea or MR will have first dyspnea, then definitely the MS chances of MS will have presented. Your history also the 1 year duration.
Yes, sir.
Rapid progression either because of recurrent carditis or combined lesion will have short history. So your patient will definitely fits pulmonary venous hypertension is the leading presentation with history of orthopnea and PND. Orthopnea and PND in the MR that are late presentation. In AR, once the LV dysfunction start, so as per your the history, the duration is very 1 year. This is not considered long. For regurgitation lesion, patient will have longer history, but your case presentation is a shorter history. So you have to we have to think of differential diagnosis in form of the stenosis superadded some regurgitation lesion. That will be the first, with already your patient developed the right side heart failure. So already pulmonary arterial venous hypertension, arterial hypertension, and right sided failure feature already sets in.
Yes, sir.
Means yeah. So it means there is some more of the mitral lesion combined. That will be the first list-wise possibility. Sudeep sir.
So important to note that the strong point here are the patient is having severe pulmonary venous hypertension
Yes.
and evidence of right-sided heart failure.
Yes.
So in presence of severe pulmonary venous hypertension and right-sided, the meaning by indirectly implicating that patient is having severe pulmonary arterial hypertension. So severe pulmonary arterial hypertension in a patient of regurgitant lesion is a very late phenomenon.
Yes,
A very late phenomenon, and then the palpitation they usually regress. The palpitation part usually regress, and the dyspnea takes over the symptomatology. So what is the duration of palpitation? I will just forget. Total duration of palpitation.
1 year. 1 year. Yes,
Oh.
mentioned 1 year. So it's, since beginning the dyspnea and the palpitation is go hand by hand as per the history.
And all these started with the episode of so-called acute rheumatic fever.
No, sir. The rheumatic fever episodes were 2 years back, and the symptoms the patient described was since 1 year.
So as per the 2-year history, doesn't appear to be too short for the develop the chronic valvular disease.
Yes, sir.
But
Sir,
what are the,
yes.
please continue.
So
the patient.
No. You're telling something. Go ahead, please. Sorry.
The patient could have some chronic valvular heart disease, which has some acute, which had an acute insult, which could lead to this kind of severe PH and severe PH in a very short span of time.
So meaning by you want to say that patient was having chronic disease, which there was some episode, some precipitative factor which led to the worsening of the symptoms.
Yes, sir.
So what are those precipitative factor do you think of in this patient?
So the patient could have developed some infections or infective endocarditis. The patient could have developed anemia. Or
just a sec. Infective endocarditis. Do you believe that this patient had the cure of infective endocarditis without IV injection?
So it is not possible because history is definitely lacking. So the 2 years back episode of rheumatic fever, one of the repeated episode that come into notice, one of the possibility in your case, because it's 12 years of age. So they led to have first acute rheumatic fever at the 12 years of age. This is also less. So some asymptomatic episode in the past, subsequent the symptomatic episode may develop sort of progressive valvular involvement. The progressive valvular involvement with a shorter history known in our country as per the rheumatic literature. Barabar? Okay?
Yes.
Okay. Then you can think of that patient, the commonest precipitative factor or the rapid progression is because of the rapid recurrent episode of acute rheumatic fever. And then the patient, the arthritis and carditis are commonly present in 75% of the cases, which is the commonest scenario. And usually the patient remember the arthritis part because the pain is very severe. The carditis part, patient usually doesn't remember because there is some worsening of dyspnea, and then patient recover then with medication or without medication. The arthritis part usually patient remember, and then arthralgia part may not be remembered correctly.
Yes, sir.
But in your case, the arthralgia was there. So even as per Jagat Narula, whenever patient having the polyarthritis is the first present as acute rheumatic fever, there are less chances of severe carditis because, but polyarthralgia may have carditis component. So in your case also fit in such natural history. It is not always so, but polyarthralgia plus recurrent in minor form of carditis subsequent that lead to hemodynamic degeneration, valvular deformation, and presentation. Okay.
Yes, sir.
So what are the other precipitating factor of this worsening of the heart failure, which you
First
should
is
be
recurrent.
ruling out in any patient of heart failure rather?
First is recurrent attacks or rheumatic fever. Second
We
is
agree.
anemia.
Hmm.
Third is infection or sepsis or infective
Yes.
endocarditis.
Yes.
Fourth is any arrhythmias.
Yes.
Hmm.
Then drug.
And use of certain drugs can also precipitate heart failure.
Which drug? Commonly used drug? Just name a few.
NSAIDs.
Yeah, NSAID is the commonest reason. Okay, which led to the salt and water retention. What else? What else in precipitative factor? Drugs. In female patient, pregnancy. And what else?
Civils. OC pills and all these things you have to think of. Barabar?
OCP.
Yes. Yeah. Sudeep sir, we can
we can
continue discussion. Let's continue
Yeah.
differential diagnosis. First differential
Yes.
diagnosis starts. Yes,
First
please.
differential.
Sir, first differential at this age group could be the patient could have a myocarditis, which have led to dilated cardiomyopathy.
First differential diagnosis, will you consider myocarditis?
Keep it simple. It is first we think of the valvular heart disease with the rheumatic background. So some valvular heart disease is the left side AV valve, that is the mitral valve involvement. And the
mitral valve involvement, Dr. Anand has led to you in the one direction, the mitral valve involvement. Why not aortic valve involvement?
Okay. Yes.
It could be, sir, bicuspid aortic valve.
So bicuspid aortic valve presenting with the severe PVH. Severe PVH and
very
PVH.
unlikely, sir.
So that is the indication that left-sided lesion which led to the severe pulmonary venous hypertension and severe PVH. The commonest etiology could be
apart from the valvular heart disease, it could be a VSD with AR.
No, just we'll discuss the valvular heart disease, then we'll go beyond that.
Beyond that, yes.
Yes, sir. It could be mitral regurgitation.
Among the valvular heart disease, which will the likely possibility in this scenario?
Sir, mitral regurgitation.
Alone or with some
alone or with some aortic regurgitation as well, or a combination of both.
Only few minutes back, Dr. Anand was indicating that the combination lesion, the mitral stenosis with mitral regurgitation, have a more rapid course of progression, and they present early.
Yes, sir.
So isolated regurgitating lesion per se, they present as with the PVH in very late condition. So in your history, the likely possibility is the mitral stenosis with regurgitation.
Mitral stenosis, mitral regurgitation that lead to the severe PVH, PH, and right side failure. That will be the first. Now come to the second. MS plus AR will be there or not? Now why?
Yeah.
Next
good question.
So MS plus AR. Yes, sir, it could be a possibility.
Yes, so that is one of the significant MS and at least hemodynamic significant AR. But only thing your case is both are present simultaneously. So still first possibility is the MSMR, second floor is MSAR. Okay.
Yes, sir.
Next.
So have you get the point which Dr. Anand was trying to bring out?
Yes, sir.
The AR has a longer history.
Yes, sir.
Okay, so but in your patient, both are almost simultaneous. So longer history of AR is not there.
There.
That's how it is it is ruling out that the MS with aortic regurgitation is less likely.
Sir.
Okay. What else?
It could be, sir, MR with AS, but no.
So MR with AS, what is the usual presentation?
So
First
MR
of-
with AS is a very deadly combination, sir, because the
Yes.
forward stroke volume cannot be accommodated because there is a stenotic lesion in the aortic valve, and also there is a mitral regurgitation. So the patient develop very severe BVH and severe PH. So
Usually they don't respond very well to the even diuretics also, because in
Hmm.
severe AS, you give the diuretics, patient remain in the class 3 class. It is a progressive disease.
Sir.
Yeah. Karan? Another differential diagnosis, any congenital?
So VSD with AR.
VSD, we are the why VSD-AR will, so always we have to apply the word the mind. Pulmonary venous hypertension, right sided heart failure, and volume overload palpitation. These are the three. Out of three, at least two symptoms should be explained by your upper differential diagnosis. All three, there is a first category of differential diagnosis. Out of three symptoms, two, then middle category of differential diagnosis. Out of one, this is a rare. Now apply yourself.
Sir, palpitation is a predominant finding in VSD with AR.
Okay, so how we going to explain the PVH and a right-sided failure? Okay, so we keep then. So it is a lower down. Then
Bicuspid aortic valve with AS with AR.
okay, so AS and AR will develop PVH with the end-stage disease. Already patient developed the advanced disease and duration of history is still short. Okay, next.
And sir, could be cardiomyopathy.
Cardiomyopathy. So usually cardiomyopathy, if for the cardiomyopathy, so how you are going to explain the volume overload or palpitation?
Sir, can lead to MR and can cause volume overload palpitation.
The characteristic of MR in the cardiomyopathy, there is such a, even the murmur is not audible. So they fail to give the palpitation symptoms of MR. Here is the large volume that LV eject that lead to the palpitation symptom in volume overload condition. In the cardiomegaly patient with MR, we never come across the symptom of palpitation. The palpitation cardiomyopathy more of the arrhythmic origin, either atrial fibrillation or NSVT or VT type. Second thing, why don't you think of another any congenital middle age, a young patient? Why not RSOV, small RSOV?
RSOVs.
So we have to just create gradually one by one. The rupture of sinus of valva that get progressive, but usually the RSOV has shorter history. We are having the one year history. But unnoticed RSOV will have such restrictive RSOV will have present such kind of presentation. Any congenital heart disease, other Luttenbacher possible?
Luttenbacher could be a possibility.
How?
Why? How the Luttenbacher is possible?
Sir, the patient has severe VVH and severe PH, but palpitation goes against that. So,
Yes.
A simple case of ASD will not have severe PVH. So, ASD with an acquired MS can have severe PVH.
ASD, if it's not non-restrictive, the patient will never have PVH.
Yes.
Okay. So can this be a patient of corrected transposition with the left AV valve regurgitation? Palpitation because of volume overload, and then in the following stage, the patient developed PVH and PH.
Yes, sir. CCTG is a possibility.
Yeah, it's a remote possibility. Yeah.
Any arrhythmia? Suppose any arrhythmia, anything you want to keep as a differential diagnosis? arrhythmic heart disease?
So, ARVC.
Yeah. But the PV, the PND
PVH.
orthopnea may not be there,
PVH,
but the patient may present with the right side heart failure and patient present with the arrhythmia.
Other is your cardiomyopathy, the tachycardia induced cardiomyopathy will have such symptoms. Tachycardia, but your arrhythmia is a volume older, so it is a low possibility. Okay.
Yes, sir.
We should go to the examination part.
Yeah. The summary for just 1 minute. The summary for the present is the heart history. You have to focus on the chip complaint. First chip complaint. We want to give the importance in the final diagnosis. Then as whether any symptoms get worsened by that presentation, we have to focus on the etiology of that valve disease and the complication of that valve disease that we have to incorporate in our history presentation. Okay. Yeah.
Very valid point.
Yeah.
On elaborating the examination, the patient is sitting comfortably, conscious, cooperative, and well-able to time, place, and person. Decubitus is of choice. Build is thin. Height is 149 centimeter. Weight of 32 kg. BMI 14.4. There is no facial dysmorphism. There is no skin stigmata of infective endocarditis. There is no pallor, icterus, or cyanosis. Pulse is 100 per minute. Regular, high in volume, collapsing in character. All the peripheral pulses are bilaterally and symmetrically palpable without any radial or radiofemoral delay. Condition of the arterial wall is normal. There is no bruit. Blood pressure is 100 by 38 millimeter mercury in right arm, 96 by 48 millimeter mercury in left arm, 140 by 68 millimeter mercury in right lower limb, and 130 by 65 millimeter mercury in left lower limb.
So can we stop at the pulse right now?
Yes.
So the character of the pulse is collapsing in character. What is collapsing pulse?
Sir, collapsing is sharp rise, ill sustained, and sharp fall.
So what is the mechanism of collapsing pulse?
So it's mainly because of recoil of the aortic recoil because of peripheral augmentation. Because in aortic regurgitation, there is some amount of venturi effect due to which the blood flows during diastole from the periphery. So that is responsible for the collapsing character of the pulse.
Okay, and then you have committed that the pulse is collapsing. It is a abrupt rise, short, and then a precipitous fall. And your blood pressure is
100 by 38 in right arm.
Sudeep sir, just said for collapsing pulse, it is very good description mentioned in the Abraham. Why it is collapsing? There is no word venturi. I read get reference. The venturi word maybe not. Its LV volume is so much large and decapitated by the regurgitant aortic valve. In AR case, we may get collapse in pulse in any hyperdynamic condition, direct thyrotoxicosis, anemia, everything. But in presence of AR, yeah, so that volume get back into the LV, that is a rapid rise and sudden fall. That's a large brisk volume, so collapsing you feel. Venturi word is not there. So whenever you present the case in the DM level, you have to be cautious, careful about each word. If the examiner pick up, how will you explain the venturi in the collapsing?
Yes.
Difficult to, yeah. Okay.
Where it is best felt?
Sir, central arteries. Sorry, radial arteries, peripheral arteries.
Peripheral artery.
Collapse in the, now what is the method to elicit? Best way to elicit?
So the patient should be lying. The patient should be lying supine, and the hand should be at the level of the heart. And first we palpate the pulse, and then suddenly we extend the arm so that we feel the collapsing pulse. It's like a water hammer pulse.
So even no need to supine, any sitting position to raise your arm above the head level.
Yes, sir.
So you will get the good character, appreciate collapsing pulse. That what described as the Abraham. Barabar?
Basically, you will feel the pulse from the bottom of the knuckle of your finger from the left hand, and you will lift the hand with your right hand.
Yes, sir.
So, and ask the patient before the lifting the hand that he should be relaxed. You will be lifting, he should not be exerting any force. Then
Yes,
you release the pulse. When you don't feel the pulse anymore, then you lift the hand and you start feeling that is the collapsing pulse.
One of the mechanisms, once you elevate the hand above the head level, the peripheral vascular region further lower down, they augment the regurgitation. That is
Yeah.
one of the mechanisms that has been explained. Okay.
yes, sir.
So BP is 100 only. There is a systolic decapitation.
Yes, sir.
Okay.
So the importance of blood pressure in the AR. There is a beautiful description for the AR. So how the AR will affect the blood pressure, systolic, diastolic, pulse. What is significant? Hill sign is very well discussed. Everyone know 20, 40, 60. So we are not touching that part.
Yes,
So now we are discussing the blood pressure. The blood pressure, systolic, diastolic, pulse pressure. Which is more important for the hemodynamic significant AR?
so high pulse pressure will be there, and diastolic blood pressure can even touch 0.
So
No. Sir was very specific. Dr. Anand was very specific. He gave you 3 options. Is it systolic pressure, which is important for the assessment of severity of AR? Is it a diastolic pressure? Is it a pulse pressure?
It's pulse pressure.
So once
No.
again, I am not agree with, because in elderly patient the peripheral arterial tone will be the higher. So the systolic pressure may be somewhat higher and diastolic pressure is low in there. But it is a diastolic pressure that determine the significance of AR, isolated AR, because
Yes,
it is become lower and lower. So it is a diastolic pressure. If less than 50, it signifies hemodynamic significant AR in absence of other associated condition. So it is not the pulse pressure. Various indices has been proposed, pulse pressure versus diastolic, all this. Finally, some conclusion is that the diastolic pressure is much more reliable indicator for the significant hemodynamic AR. Now tell me, as we already discussed the Korakov sound and we measure the blood pressure up to the 0. So actually it will up to the 0, but there is a fallacy in our assessment.
Sir, we actually take the fourth sound as the diastolic blood pressure.
Yes, that is Korakov fourth sound will take. But important is it never, diastolic pressure never fall below the LVDP. So our method for assessing the blood pressure is maybe the fallacious to we are measuring up to the 0 the diastolic. So it is related to peripheral arterial wave that will give the false impression.
Yes,
so
sir.
it never fall below the LVDP. Okay.
Yes, sir.
Sudeep sir.
Go ahead. I think.
Yeah.
The JVP is pulsatile. The mean JVP pressure of 3 cm above sternal angle. There's a prominent CV wave.
Is it raised or not raised?
It is not raised, sir.
So you have to mention 3 centimeter above the sternal angle in the sitting position versus 30 degree of position or versus 15 degree of position. They have a different connotation.
Yes, sir. It is in the 30 degree position, sir.
Okay.
So, and have you measured the total JVP?
So it is just visible.
No. Have you measured?
Sir,
Ideally, you should measure it. Ideally, should measure it. And then commit whether it is raised or not raised.
Yes, sir.
Then examiner will discuss how did you measure the JVP and come to the conclusion whether it is raised or not.
Yes, sir. There's a prominent CV wave with normal respiratory variation. And
What about the descent?
So the Y descent is prominent.
X descent present or not?
X descent I could not appreciate, sir. So
only single waveform you want to say?
Yes, sir.
All right. So single systolic, almost systolic waveform you are able to appreciate in JVP.
Yes, sir.
So what is normal respiratory variation?
So the JVP falls with inspiration and rises with expiration.
Okay. We'll discuss later on your final diagnosis. And hepatojugular, what do you say?
Hepatojugular reflex is negative.
Reflex or reflux?
Reflex.
It is reflux.
LUX.
LUX. Reflux is negative. How do you elicit hepatojugular reflux? What is the importance of eliciting this?
Sir,
Your
it
JP
is
was raised or not raised? First,
not
let us-
raised.
not raised. Is it important in this patient or not?
Yes, sir.
So how did you elicit hepatojugular reflux?
So you can press over the abdomen, over the umbilicus, or over the right hypochondrium for about 10 seconds. And normal response is the rise is JVP is less than 3 centimeter, and it persists for transiently for less than 15 seconds. If it rises for more than 3 centimeter and persists for more than 15 seconds, then hepatojugular reflux is positive.
Slight correction. You press for 30 to 60 seconds. Okay. There is a transient rise with rapid fall. It doesn't persist to rise. Okay.
Yes,
then it is said to be negative. If it is present, so what does this signify?
It's an incipient right heart failure.
Why not left heart failure? It is also described in the left heart failure also.
Left heart failure also, sir.
Yeah. Okay, go ahead.
The respiration is 18 per minute, regular, and abdominal thoracic. The patient is afebrile to touch. There is no pedal edema. Peripheral signs of AR are present.
So, what are those peripheral signs?
One was pistol shot sign was present, and the diuresis sign and diuresis murmur was present. And the patient also had Muller sign.
Okay, we'll not go into detail because go ahead.
On elaborating the CV examination proper, inspection, shape of precordium is normal. There is no precordial bulge. Apical impulse is seen in the left 7 intercostal space, lateral to the midclavicular line. There is multiple visible suprasternal and carotid pulsation. There is no scar, sinus marks, or engorged veins. There is no spinous abnormality. On palpation,
Okay, let's finish the finding. Please finish the finding.
On palpation, the apex beat is felt in the left 7 intercostal space, lateral to midclavicular line. It is LV type, hyperdynamic, and there is a systolic trill. There is palpable P2 present at left 2nd intercostal space. There is a palpable S3. Grade 2 left parasternal heave is present. There is epigastric, carotid, and suprasternal pulsation is present.
So you want to say it was a left parasternal heave. It was not parasternal pulsation. Can you elaborate a little bit about this grade 2 left parasternal heave?
So it is grade 2 because it is palpable and obliterable, and it is left parasternal heave which is synchronous with the apex. So it is mainly a right ventricular hypertrophy type of pulsation.
Okay.
So in your inspection finding, just what are the different causes of left parasternal heave? One is the pulmonary hypertension. What are the other pulsations we can felt at the left parasternal region? How will you differentiate?
Sir, also there is LA enlargement can also cause parasternal heave.
How can differentiate the left parasternal heave or LA enlargement versus
If it is synchronous with the apex, it is due to RV hypertrophy. If it is not synchronous with the apex, it is LA enlargement.
But there is
else? So you committed that it was a right ventricular hypertrophy which can lead to the left parasternal heave. Can right ventricular volume overload cause left parasternal heave or other pulsation?
Parasternal pulse impulse can be felt in RV enlargement.
Give one example where it helps in to differentiate between the volume overload type and the pressure overload type. Give one classical example. Right ventricle pulsation, volume overload type versus pressure overload type.
ASD.
In a patient of ASD, yes. If the ASD is without significant pulmonary artery hypertension, it will be right ventricular parasternal impulse, and it will be compressible. It will not be sustained. When it becomes sustained, it means there is a significant pulmonary arterial hypertension.
Yes, sir.
And regarding the cardiomegaly, so usually the two diseases where we get the cardiomegaly, MR and AR. So in which disease it is more, you will get more cardiomegaly? AR or MR? Same intensity.
Sir,
Severe MR, severe AR or severe MR? In which
Severe
will
AR.
you will severe AR? Why?
Why?
Yes, you are right.
Sir, because in severe MR, the regurgitant jet has got two orifices to go out. It can enter into the LA and also into the aorta.
So yes, good. So it is a more of the cardiomegaly 6 and 7 intercostal space. They more favor the aortic regurgitation. That is one of the good.
Yeah, seventh intercostal always think of aortic
Yeah.
regurgitation, less common in the mitral
Yeah.
regurgitation, but it can be there.
Yeah.
So just one more question. The cardiomegaly, the presentation, the question again remains the same. And the excessive cardiomegaly is not present with the mitral regurgitation. Whether the patient will present with the cardiomegaly or less cardiomegaly, what is the main determining factor in this? Patient by mitral regurgitation, some patient present early, some patient present late, and who present with late, they present with the cardiomegaly, significant cardiomegaly, and some patient present early, but they don't have so much of cardiomegaly, but they have cardiomegaly, but not so much. So what is that determining factor, which is
LV end-diastolic pressure?
It is LV end-diastolic pressure. Obviously, end-diastolic pressure is a late phenomenon. You mean to say that it implies your implication is the LV function.
Yes,
Important is the LA compliance.
Yes, sir.
Yeah, if LA compliance is less, the patient present with the pulmonary venous hypertension, they present early, so there is less chance of use cardiomegaly. And the compliance is more, than the LV gets keep on dilating, and they present a little late. The
Yes,
compliance of LA is very important in mitral regurgitation.
Yes, sir.
Go ahead. Continue. The percussion part, you have missed that.
Okay, not significant.
The right heart border is substernal, left heart border corresponds to apex, the left second intercostal space is resonant, liver dullness present at right fifth intercostal space at the mid-clavicular line.
Okay.
Yeah, multiple visible suprasternal and carotid pulsations in. So you are not mentioning and recording comment in the palpation. What are those pulsations?
Sir, first is the epigastric pulsation.
Multiple visible suprasternal
pulsation is because of hyperdynamic states. It could be because of severe ARs in this patient.
Okay. Next. Come to the serious examination. Auscultation.
On auscultation, S1 is soft, S2, A2 is soft, P2 is loud, split is normal. There is S3, there is no S4. There is no ejection clip.
Can we stop here?
Or
can we stop here?
Yes, sir.
We'll just concentrate on the sound. You said S1 is soft, S1 is soft, A2 is soft, and
Yes,
P2
sir.
is loud.
Yes,
So
sir.
why do you say S1 is soft? And why do you say A2 is soft?
So S1 is soft because S1 is heard only over the apex. It is not heard over the base.
Okay, good.
A2 is soft because it is not heard over the apex. It is heard only over the aortic area.
Good. Right. And P2 is loud. But then how will you say it is P2 is loud?
P2 is loud because P2 is heard in the P2 is heard over more intensity over A2 in pulmonary area, and also P2 is heard over the apex.
Okay.
And how sure are you that it was a P2, it was not A2?
Sir, because A2 is not heard about the apex, so I think that loud sound in
that is my question. That is my question. Why not? It is A2. It could be A2, which is very loud, and P2 is soft. P2 is absent. Whatever the reason, why not? It is A2.
Sir, because I've already found features of pulmonary hypertension in this patient, so P2 has to be loud.
Yeah, and your P2 was palpable, I think.
Palpable P2 we got.
The left external AU.
Left external AU, P2 is palpable. So, all right.
Yes, you are.
Go ahead.
Good.
About the murmurs, an apex, there is a high-pitched, soft-blowing, pansystolic murmur of grade 4 intensity, radiates to left axilla, best audible with diaphragm stethoscope in left lateral position, and increases with expiration. A short, low-pitched, mid-diastolic murmur in apex, best audible with the diaphragm stethoscope in left lateral position, and increases with expiration. There is no opening snap or presystolic expansion of the murmur. Auscultation of the aortic area, there is a high-pitched, soft-blowing, decrescendo type of early diastolic murmur starting from A2, heard in the right second intercostal space, more prominent in the neo-aortic area. It occupies more than 2/3 of diastole, best audible in sitting and leaning forward position, and with the diaphragm stethoscope. The murmur radiates along the left sternal border and is augmented with deep expiration. Auscultation of the lower left sternal border, there is a pansystolic murmur of grade 3 at the lower left sternal border, high-pitched, blowing in character, best heard with the diaphragm stethoscope in supine position, and increases with inspiration and decreases with standing and expiration.
Just tell me how is the MR murmur intensity is soft blowing and the TR murmur is the high pitch blowing. So what is the normal rheumatic MR? It is more of frequency is the medium pitch, high pitch, and it is not soft. When you have significant MR,
yes, sir.
if you are grade 4 intensity, so the soft blowing murmur rather than soft blowing. Barabar? So I said this is left lower parasternal region, either you are appreciating the same MR murmur. How will you differentiate between MR versus TR?
Sir, the TR murmur increases with inspiration. So it is a Carvalho sign occurs in TR murmur, while MR murmur increases with expiration.
Yes.
So, just a hypothetical question. This patient had a right-sided heart failure. Okay.
Yes, sir.
So, meaning by that right and severe tricuspid regurgitation, meaning by the severe pulmonary arterial hypertension. Okay.
Yes, sir.
So, in the severe pulmonary arterial hypertension, most likely this patient is having right ventricle hypertrophy. And this right ventricle hypertrophy, which is working at the Starling curve, you can say that it's at the plateau phase or something like that.
Yes,
Agreed? Because
yes,
he had right-sided heart failure. In this situation, whether this maneuver will change the murmur?
So the respiration, inspiration, expiration will able to give the hardcore clue to differentiate in presence of severe pulmonary arterial hypertension.
It is unlikely.
So that is more important. It is unlike. Though the chances of inspiration, expiration effects on the dynamic auscultation will be the less. So what are the other methods you can incorporate to differentiate among all these murmur? And regarding the MDM at the apex, so either is the organic mitral stenosis or functional or Austin Flint.
Sir, the MDM at the apex is a short duration murmur. It is low pitched and there is no opening snap and pre-systolic accentuation.
Okay.
So it is unlikely to be organic MS.
Unlikely.
So opening snap may not be there. Maybe this patient is having, because he is having soft S1, maybe having calcific MS, and the patient is not having any opening snap. That is one explanation for absence of opening snap.
Yeah. And
patient is presenting with a severe pulmonary arterial hypertension. We have already discussed the combination lesion of MSMR is more likely in comparison to isolated mitral regurgitation. So again, Dr. Shukla has asked a very pertinent question. Is it not a murmur of mitral stenosis?
Sir, there is no pre-systolic accentuation.
Okay. So what are the dynamic auscultations you have differentiate? Having the mid-diastolic murmur in your case, probable 3 different etiology. One is the organic microstenosis, one is the severe MR that lead to mid-diastolic rumble, third is the Austin Flint.
Yeah.
So among these, what is the possible explanation for the mid-diastolic murmur?
So it could be functional murmur of MR.
Why not Austin Flint?
Austin Flint and functional MR murmur cannot be ruled out in this patient because the patient has got severe AR as well. So
now we theoretical, how will you differentiate MS versus Austin Flint?
MS versus Austin Flint, the S1 is loud in organic MS, while the S1 is normal.
Dynamic auscultation. Which bedside dynamic auscultation will help to differentiate?
Sir, isometric exercises.
Isometric exercise will do. So just I am giving the group. You have to reduce the peripheral vascular resistance, systemic vascular resistance. The which dynamic auscultation will? One is the amyl nitrate, that is we don't do routinely. Another is the isotonic exercise. So what will effect of isotonic exercise on AR and MS?
Sir, the PVR will decrease.
PVR is important or SVR is important?
Sorry, SVR will decrease.
So
what will happen to AR? What will happen to MS? That is how you differentiate. If the peripheral SVR is decreased, the AR will decrease or increase?
So the flow will be more towards
forward flow will be more, so there will be less.
There will be less of regurgitant flow.
Okay.
The basic concept is that to give AR treatment medical management, we reduce the afterload. Similarly, if you are reducing the afterload, they will decrease the intensity of the AR. So by the isotonic exercise, the AR murmur will be attenuated and MS murmur will be accentuated. So you can differentiate bedside. Okay. Now, one is the thing that you are not getting the Bisperine pulse in the carotid. The significant AR is double regurgitant lesions are there, but you are not getting the Bisperine pulse in the carotid. No ejection flow murmur in the LVOT.
No, there is no ejection flow murmur in the LVOT.
In LVOT.
No, sir.
You are presented in such a way that TR also. So ejection with underlying presence severe significant AR, some ejection systolic murmur with the early peaking is always there even in absence of AS.
Yes.
Because the same flow has to cross the fixed aortic wall. It is fixed aortic wall. Large volume has to cross and same volume regurgitate back to the LV. Some flow murmur will be there. Okay. And high pitch early diastolic. Okay. Sudeep sir, anything?
That's a very important finding which is not there. That almost your description is suggestive of a severe aortic regurgitation, cardiomegaly, and the presence of So then there should be some flow murmur. So what is the explanation of the normal split in this patient? What do you expect in the severe aortic regurgitation?
Sir, in severe AR, the split.
The length of murmur is more than 2/3, and there is some suggestion of flow rumble, Austin Flint number, AFL. And so in this scenario, in the large aortic regurgitation, what is the likely split?
Sir, in aortic severe AR, the split should be narrow or it can be paradoxical.
Why?
Because of increased hangout time, the aorta, because of increased compliance.
Hangout time in aorta, they are not what it's more on the pulmonary circuit, not the aortic. So please, Sudeep sir, please.
Is it because normal split is caused by what are those components? One is pulmonary component, one is the systemic component. What is the different percentage of contribution to them?
Sir, hangout interval mainly on the pulmonary component. Interval is about 80 millisecond in pulmonary and about 30 millisecond in aortic. And also depends on the RV ejection time.
One is so there are three parts. One is hangout interval, one is the ejection time, and one is the decreased ejection time on the left side.
side.
Okay.
Yes, sir.
So decrease QA2 interval is also important. That is almost contributing 1/3, and then it increase RV ejection in the inspiration almost 23-27%, and another 48-50% contributed by hangout interval.
Yes, sir.
So in aortic regurgitation, what is increased? It is ejection phase. Large volume is ejecting, right? That is the main reason. And what about the in mitral regurgitation? What will you expect in this patient?
In mitral
About
regurgitation,
the
the split
split.
is usually wide, sir.
Wide variable.
Wide and variable.
Wide and variable. And you are getting a signs of severe pulmonary arterial hypertension.
Yes, sir.
So what will be the split in this scenario?
So in severe PH, the split is usually narrow.
Narrow or paradoxical.
Yes, sir.
Sudeep sir, there is 10 minutes left. After that, you have to present. So we can go to the final diagnosis and how we determine the severity of lesion? We can discuss it out.
Next slide.
On abdominal examination, the liver dullness is felt in the upper border in the right
Come to the
space.
final diagnosis.
Final diagnosis.
Diagnosis: rheumatic heart disease, severe MR with severe AR, with severe TR, with severe PH, with severe PVH, in normal sinus rhythm, in NYHA class 2 at present, with no evidence of infective endocarditis or congestive cardiac failure at present.
Without JVP race, do you have severe TR, severe PH, severe PVH?
So the patient has got history of orthopnea and PND. So
No. Your JVP is when you examine the patient, after that you have made the diagnosis, severe TR, severe
yes,
PH. The JVP should be at least some remarkable rather than the unremarkable, other than the CVV. Okay, both components are there, the PVH and PH are there. The Y is on which basis you have made the diagnosis of severe MR. What are the clinical parameter? History as well as clinical parameter favor the severe MR.
Sir, because the patient has got a very short history of dyspnea and has given rise to very severe PVH and severe PH with history of orthopnea and PND. So a mitral lesion is more likely. And in this setting, severe MR is more likely as per the clinical context. Also in clinical examination, there is presence of S3 and a functional mid-diastolic murmur over the apex. So that is a clue towards severe MR.
So again, coming to the same question, the severe TR. What is the signs in this patient about that the patient is having severe TR?
So the prominent CV wave in JVP.
Yes.
And
rapid V wave descent, you can say. Only the single wave form that suggests severe tricuspid regurgitation. Okay.
Yes, sir.
And in this patient, the murmur is pansystolic. You don't imply that it's organic tricuspid valve disease because of severe right ventricle hypertrophy, features of severe right ventricle hypertrophy. So there is severe PH. Okay. So
Yes,
which is the dominant lesion in this patient? Severe
So,
mitral regurgitation or severe aortic regurgitation? Again, Dr. Anand was asking why severe AR. Just first explain why severe AR, and then come to the question, which is the dominant lesion?
severe AR because the patient has got peripheral signs of AR, and there is a early diastolic murmur which occupies more than 2/3 of diastole. So there is a long diastolic murmur, and there is also decrease in diastolic blood pressure.
And why you are not getting the Hill sign of significant AR?
Hill sign is present, sir.
No, only 40 or less than 40. How much is there? 100 and 140. 40, maximum 40 is there. Usually insignificant. The Hill sign when we 20 to 40 moderate, more than 40 is significant. Am I right?
Yes, sir.
So here you get the 40. What is why it is so?
So because of severe MR, the regurgitant flow has flow back to has gotten a second orifice towards LA. So
and we have one observation. There was a systolic decapitation in this patient. So what is the explanation about that?
there is also
When you
secondary to severe MR, sir.
Some
Because
LV
the forward volume would be
some
decreased in
LV
case of severe.
dysfunction, my component might be there based on it. Some.
Yes.
See, you have not committed on the LV function.
So LV function in this patient is at present it is normal because still the peripheral signs are audible.
Okay.
So peripheral signs are can be audible in other associated conditions. So which is the most specific? But see, your patient is severe mitral regurgitation and severe aortic regurgitation, and you are having a severe PAH. If the patient develops LV dysfunction, so what will be the change which you anticipate in these patients, in the patient of severe mitral regurgitation and severe aortic regurgitation?
So with LV dysfunction, the peripheral signs of air will diminish.
Okay, what else?
And
whenever you are asked about these type of questions, start from the inspection, palpation, percussion and auscultation like this, or the most specific findings. Start with.
Sir, in LV dysfunction, first there will be systolic decapitation of BP. In palpation, the apex will be more of heaving and ill sustained.
See, heaving or ill sustained are oxymoron.
Yes, sir.
So what will happen to the apex? In severe aortic regurgitation, it's a hyperdynamic type of corpus ill sustained. What happened to the apex when there is a appearance of LV dysfunction?
It will be more diffuse, sir.
It's more diffuse, or some people say it becomes more sustained. Initially, yes, it is forceful. Then it becomes the duration of duration increases, and then it becomes diffuse, and then the area of apex is also increased.
Yes, sir.
Okay, what about the other signs? If it is isolated aortic regurgitation, LVS3 will be more prominent.
Yes,
and
sir.
What about the murmur, duration of murmur?
It will diminish, sir.
It will diminish. What about the S2?
S2 will be it will be fixed split.
That's a very late form.
Okay. So Sudeep sir, we can ask you any of query from your side you want to ask us. Now throughout 1.5 hours we ask you the question. Any dilemma present in the case you are having, so we can help it out.
Sir, I'm still confused with the split in this patient.
Okay.
Should we do it the split? Because
theoretically you gave the good answer for the splitting. First
yes,
thing, we have to start from the base and etching method. First we have to, at the base, left and right, we have to auscultate and find out that confirm. As per LPH is there, left parietal heavy is there, whatever the louder component will be, the P2 definite will be there.
Yes,
from etching method, we can have good assessment or the assessing the S2 split. Theoretically, you give the correct answer. How you can give the S1 is soft and A2 is soft and P2 is loud. That is perfectly correct. Second thing, you are just missing the ejection systolic murmur at the aortic area. In significant ER, there is always some ejection systolic murmur will be there. Importance of clinical assessment, apart from your exam, when you become clinician, always there is a overlapping symptom. It is echo is also not 100% sure. Then you have to rely on the clinical and yourself. So if your clinical judgment and assessment is perfect, we can defer the patient per subject for the surgical intervention. Suppose if in echo, sometimes we overestimate the lesion or underestimate the lesion. At those moments, the clinical assessment, if your fundamental clinical assessment is right, you feel that then you can add on the finding for the grading of or severity of the lesion. That's why this clinical exam is important even in the private practice, or not only because of the exam. Sudeep sir, you can start.
So one
Just-
more thing, how to
Yeah.
differentiate between the Ostenflin murmur and the functional mid-diastolic murmur of MR.
So functional mid-diastolic murmur of MR get accentuated with if isometric exercise, the AR will increase and MR will decrease. Isometric.
Yes, sir.
MR also increase in both isometric exercise. Because it is a flow related. Now, the mechanism of MDM in MR and the Ostenflin remain more or less same. There's some three theory of the Ostenflin. One is the diastolic MR, one is the premature closure of the mitral valve, and third is the functional narrowing of the mitral valve. But premature closure of AML is one of the mechanism, but difficult to differentiate with the MDM of MR versus Ostenflin. Sudeep sir?
So important to note that MDM in severe mitral regurgitation is a rare phenomenon. If you are getting MDM in a severe mitral regurgitation, almost always consider associated mitral stenosis. One must remember. So quickly we'll go to the ECG and X-ray in this patient, and then we'll go to the presentation. So do you have any ECG or X-ray? Okay.
Yes, sir.
So describe the ECG.
This is a 12-beat ECG in normal sinus rhythm with a heart rate around 110 per minute, with a mean frontal QRS axis of plus 90 degree, with features suggestive of left atrial enlargement as evident by terminal P wave deflection more than 0.04, with LVH, left ventricular hypertrophy of volume overload type.
Important is this ECG was taken in the half standardization. So whatever
Yes,
you
sir.
appreciate, see more, you have to pick up first sentence. This is
Yeah.
half standardization.
If this standardization is not given, then you cannot get that it's a increased PTF.
Half standardization. So
there is a left ventricular hypertrophy of volume overload type.
Volume overload. We expect the left ventricular hypertrophy, LA enlargement, and right axis deviation. Right axis deviation, I am not convinced for the right axis deviation. Why you say 90 degree?
It is around plus 75 to 90.
So,
not crossing 90. LA enlargement
19 is not. No, it's less than 90.
The volume overload definitely is there. LA enlargement definitely is there. Barabar?
Yes, sir.
So can we differentiate this type of picture, whether the dominant lesion of aortic regurgitation or mitral regurgitation? Very difficult to differentiate.
In mitral regurgitation, there is early transition of.
Why?
It is basically because of LA enlargement.
Yeah. Some people have, but it is not very. It's not very specific.
And the
Go to the X-ray.
I told T wave they are missing in this case. So volume overload. It may be because of digoxin or because JT interval is short. So patient must be on the lanoxin anything. Some U wave is there. So you have to think of all this. This half standardization. X-ray.
Yes, sir. This is chest X-ray, PA view.
Yes.
Taken in full inspiration with slight left side rotation with adequate exposure. With
left
a characteristic
posterior.
Left posterior. With a characteristic ratio of 65%. With LV type of apex. With features suggestive of LA enlargement as suggested by widened carina, elevated left main bronchus, and double lateral shadow. With right atrial enlargement as evident by right heart border becoming more convex. Right border extends more than 3 intercostal spaces, and the measurement from the mid vertical line to the maximum convex diameter is more than 5.5 centimeter. There is full obliteration of the pulmonary way, suggestive of a dilated MPA with
Bay.
enlarged.
Why do you say bay? Bay is the concavity.
Obliteration of the base.
No, you're saying the pulmonary artery segment is fullness.
Fullness of
is there.
MPA segment with enlarged right descending pulmonary artery, suggestive of severe PH, and also there is grade 2 PVH.
So, any evidence of the ascending aortic enlargement?
No, sir.
And any evidence of the SVC dilated on the X-ray because your severe TR?
Severe TR and the RA dilatation. You have already committed.
Yes, sir.
Your percussion finding is right border is retrosternal.
Yes, sir.
So you have to see the properly. If you are already committed for the so much RV dilatation, RA dilatation, RV dysfunction, always look carefully. Okay.
Yes, sir.
You may be right, but always this because there is apparent right-sided enlarged shadow enlargement is there.
Yes,
okay. Sir. Yeah.
So what will you do to this patient? What is your recommendation?
Double valve replacement, sir.
Why you say double valve? Double always theoretically you will always look for you if you preserve the valve, that is the best, because double valve replacement itself carries their pros and cons, long-term anticoagulant and all these things. If the precipitative repair will be there, they'll always look for. Though nowadays no one is doing the repair, but theoretically definitely there are criteria which patient can undergo the repair surgery. So answer will be that I will go for the econ assessment and see the significance, severity of valve, and then send for the surgery, the double valve versus single valve. सुदीप सर आपका लेक्चर स्टार्ट करते हैं, ऑलरेडी टाइम हो गया 1 बजे
we'll start and this is I think just stop sharing the screen, Sandeepan.
Yes.
Your present. Yes, sir. Please.
So I will be just discussing few of the clinical points regarding the question which were asked during the examination about what is the medical management and how to assess the severity, etc. I will be just focusing on that. My outline will be about the discussion will be the how to identify the dominant lesion clinically, and then what is the stages of progression of disease and etc. And then how to follow up in the asymptomatic patient and prevention of rheumatic fever, about especially the prophylaxis, especially the penicillin prophylaxis, and then individual medical management of individual disease and what we should be doing about the moderate disease. So in the combined lesion, if you see that first we'll discuss about this. My voice is breaking. Let me.
No. Yeah, perfectly okay.
Okay. So in the patient of combined mitral stenosis and mitral regurgitation, so if you are not able to differentiate which is the dominant lesion, then you go for the symptoms. If the patient present with the palpitation, then the dominant lesion could be regurgitation. If the patient with the PVH, obviously this is the mitral stenosis. And then finding suggestive of right ventricle hypertrophy or PAH is the early finding in the mitral stenosis and late in the mitral regurgitation. If the patient is having combined mitral stenosis and mitral regurgitation, remember this patient will be having early onset of mitral pulmonary arterial hypertension because of the volume as well as the pressure overload. So remember, these patients present early and they have much more pulmonary arterial hypertension. Even you can see that the moderate mitral regurgitation and moderate mitral stenosis may be having a severe pulmonary arterial hypertension. So right ventricle hypertrophy, if there is a apex is the RV type, obviously this right ventricle hypertrophy is present. This MS is dominant lesion. If the LV is, if the apex is LV type and hyperdynamic or down and out, then the MR is a dominant lesion. And then if the thrill is obviously diastolic in the mitral stenosis and the systolic thrill, if it is there, always remember that the palpatory findings, they are considered as a hard finding, and they were given preference over the auscultatory finding. So palpatory findings are more important compared to the auscultatory finding. And then the patient is having long diastolic murmur. Obviously, this is a mitral stenosis murmur. The presence of S3. S3 denotes there is a significant mitral regurgitation. Even it is absent in the combined lesion. So, right, severe PH, signs of severe PH. It is more present in the mitral stenosis, as already discussed, and the combination lesion, and the less common because it is late phenomena in the isolated mitral regurgitation lesion. Similarly, the right axis deviation, right ventricle hypertrophy, it is more common in the mitral stenosis compared to the mitral regurgitation. In the balanced lesion, when the more is severe, the left ventricular hypertrophy you can be getting, but remember the patient present early, the signs of right ventricular hypertrophy are usually not there in the balanced lesion. And in X-ray, similarly, you will find in the X-ray the LV type, dilated LV suggest severe mitral regurgitation, whereas the less cardiomegaly or RV type of X-ray suggests the mitral stenosis. Other lesion that we discuss about the aortic stenosis and aortic regurgitation. Similarly, that presence of triad, any symptoms of angina, syncope, or dyspnea. It's more common in the aortic stenosis dominant lesion rather than aortic regurgitation. Patient with aortic regurgitation can present with the angina, which is a classically said to be nocturnal angina, present on the rest, and it is a less common feature or symptoms in the chronic aortic regurgitation, whereas the angina is a common symptom in aortic stenosis. Signs of PVH is a late phenomena in this group of the patient, and if the patient develops dyspnea on injections, remember the prognosis of aortic stenosis very limited. We all know that the 235 figure of 235. If there is a cardiomegaly is very prominent, then it is a predominant aortic regurgitation lesion, and it is less common in the balanced lesion, and that is usually not present in the isolated aortic stenosis lesion. The classical described is a forceful sustained apex in the AS, whereas the force pole is sustained in the aortic regurgitation. We already discussed about how it changes with the LV dysfunction. It become sustained and then diffuse, occupy more than two spaces, and the patient develops LV dysfunction in patient of aortic regurgitation. S3 or S4 is more common in aortic stenosis because the stiff LV and the stiff LV, there is aortic atria contract against the stiff LV. The S4 is more common in. And then Abraham writes the S4 is more easily seen, S3 is more easily palpable. So when you are feeling the apex in any patient, the movement of your finger, just carefully watch those movement of finger, that will give you clue whether it is S4 or S3. If the impulse is present on the ascending limb of your apex, that is S4. If it is descending limb of apex, then it is S3. So thrill, systolic thrill is common in aortic stenosis, can be there in the balanced lesion, but it is diastolic thrill is rarely present in the severe aortic regurgitation because it's a high-pitched murmur, and high-pitched murmur are usually not felt. High-pitched any vibration are usually not felt by our bare hand. Paradoxical split is common it can be there in the severe, very severe aortic regurgitation, but it's common in severe aortic stenosis. Similarly, in the ECG, you will find that the pressure overload type in the whereas you will find in the volume overload type and the prominent septal Q wave, the upright T wave, whereas then the hypertrophy, the LVS with the strain, ST depression with the TV inversion and without any Q waves. And this is a common combination which you'll get in the examination: aortic regurgitation and mitral stenosis. If there is any history of angina, then it suggests that the patient could be having aortic stenosis or aortic regurgitation. Aortic valve disease is more common, whereas this angina symptoms is never there in the mitral valve disease. Effort intolerance is more common in the mitral stenosis because of the PVH and decreased cardiac output. And remember that proximal lesion attenuate the signs and symptoms of distal lesion, meaning by if the patient is having mitral stenosis, signs of aortic stenosis will be masked, but aortic regurgitation will not be masked because it is a regurgitant lesion. If there is a less filling of the left ventricle, there will be less outflow into the aorta. The signs of aortic stenosis will be masked, but aortic regurgitation are usually not masked. Pulmonary symptoms, meaning by pulmonary venous hypertension symptoms, are more common in the mitral stenosis, not in the aortic regurgitation. We already discussed about the history of thromboembolism, which can be there in the mitral stenosis, but never in the aortic conditions. Pulse is very important. Wide pulse pressure practically rules out predominant mitral stenosis. It suggests that there is a severe aortic regurgitation. And the parasternal lift or right ventricle hypertrophy features of pulmonary arterial hypertension, all this suggests that the mitral stenosis lesion is the dominant lesion. Presence of S3, S4 cannot be found in the mitral stenosis because the stenotic there can't be any increase in the flow with the atrial contraction. So S4 is never present in mitral stenosis, but S3 or S4 can be there in the presence of severe aortic regurgitation without any significant mitral stenosis. We already discussed the effect of gastric rumble, etc., and the ECG. As we all know that if there is a right ventricle hypertrophy, it practically says that it is a predominant mitral stenosis. Left ventricle hypertrophy is present in the predominant aortic regurgitation, and it can, if the balanced lesion, it can be there. Atrial fibrillation always suggests that the predominant lesion is the mitral stenosis. This is another combination which you often get in the examination: aortic stenosis and mitral stenosis. We already discussed that the syncope or angina is not a common feature of the predominant mitral stenosis. It suggests that the aortic stenosis is the dominant lesion. Whereas the pulmonary symptoms, meaning by dyspnea, etc., is a sign of pulmonary venous hypertension, is common in mitral stenosis, predominant mitral stenosis lesion. Systemic emboli, we already discussed, suggests that the mitral stenosis is a real problem. And regarding the pulse, it is very, very important to assess the pulse. That delayed peaking suggests a significant aortic stenosis. Delayed peaking suggests significant aortic stenosis, and the apex is forceful and sustained. It suggests the aortic stenosis is the dominant lesion. Rumble, we know that if the patient is having feature suggestive of right ventricle hypertrophy or pulmonary arterial hypertension, the predominant lesion should be mitral stenosis. And atrial fibrillation also suggests the dominant lesion is mitral stenosis. Chest X-ray, ascending aorta is dilated in the aortic stenosis, whereas the left atrial dilatation and right ventricle hypertrophy is a common feature in the mitral stenosis. Aortic stenosis and mitral regurgitation is a rare combination. These patients are very sick, so never expect these patients to be given in the exam. And tricuspid, organic tricuspid valve disease associated with the mitral stenosis. So, in the patient with organic tricuspid valve disease, we see that PND and orthopnea, they are very equivocal findings, and they could be there in the organic tricuspid valve disease or not disease. But when you see that the patient present with early fatigability, patient with the right side congestion, patient with the right ventricle, meaning by right side congestion, then you suspect that the organic tricuspid valve disease. And the giant A wave or prominent A wave, slow wide descent, it is a synonym of the tricuspid stenosis. And sometimes you can appreciate the split of S1 because of the tricuspid stenosis, and S1 is very loud. And if there is a stenosis, there is a less filling of the right ventricle, and then the pasternal heap is not very prominent in the patient with the tricuspid stenosis. So we know all about this stages of progression of valvular heart disease: at risk, progression, asymptomatic, severe. It is a classification given by the American College of Cardiology in guideline of the valvular heart disease. Progressive, at risk meaning by patient already had one episode of, for example, patient had one episode of rheumatic fever, but is not having valvular heart disease, it is at risk. Or patient is having a bicuspid aortic valve, but is not having any aortic stenosis or aortic regurgitation, but it is at risk. Progressive meaning by the mild to moderate lesion is there, but patient is asymptomatic. And then the class stage C is the asymptomatic severe. Patient is asymptomatic and without any, with the severe lesion. It can be grouped in the C1 or C2. C1 is the patient is asymptomatic with severe valvular heart disease, and where there is no left or right ventricle is compensated. Whereas the C2 is the when there are left and right ventricle is non-compensated. For example, patient of severe mitral stenosis, a patient developed right ventricle hypertrophy, heart failure, or severe mitral regurgitation with the dilatation, and there is LV dysfunction. Then it will be grouped into the C2. And then the patient becomes symptomatic, it is said to be a stage 3. So whenever you send the patient for any intervention, always remember it depends on the following condition: whether the patient is symptomatic or not, and what is the severity of valvular heart disease, whether it is really severe, and then what is the response of the left or right ventricle on the volume of the pressure overload caused by the valvular heart disease. For example, severe mitral stenosis, patient is having right ventricle hypertrophy or severe evidence of right pulmonary arterial hypertension. It suggests that it needs intervention. Similarly, severe mitral regurgitation patient, if patient having LV dilatation, then it suggests that patient may need mitral valve replacement or repair surgery. It depends on the cutoff of which we'll discuss later on. And then the effect on the pulmonary or systemic circulation, we already discussed. The patient is severe mitral regurgitation asymptomatic, but patient is having pulmonary hypertension. He should be subjected for mitral valve repair or replacement. And change in the heart rate, we'll discuss. If patient develop atrial fibrillation, he almost always become more symptomatic. But if it is not symptomatic, then still it's a class 2A indication for sending him for the surgery in a patient of mitral regurgitation. Why it is important to refer timely? Because we know that the patient having a normal ejection fraction, mitral regurgitation, if the patient is presented, sent for the surgery in the late condition, the prognosis is poor. And similarly, the same condition, functional class, but the patient is sent when the LV is started deteriorating, the prognosis is grave. So we have to watch for the symptoms as well as the LV dimension or other features which we've already discussed, the effect on the response of the left or right ventricle on the presence caused by the valvular heart disease. So how to follow the asymptomatic patient? This is you can say that it is guideline by the ACC. Recently, ESC guideline have been published, but ESC doesn't mention about this. How often do we follow and how often we do the echocardiography? So any patient who present with a change in symptoms or physical findings, they should always be sent for the echocardiography. For example, if you are following a patient of mitral regurgitation, for there is a change in the quality of the murmur. It becomes squealing, or there's a musical quality of the murmur. You always suspect that there is some change in the characteristic of the valve structure, which led to the change of the this quality of the murmur of the patient was doing fine and become more symptomatic. You always subject these patients to echocardiography. Mild disease at least every 3 to 5 years. Moderate disease, what we recommend is every 1 year, and the severe asymptomatic every 6 months. And if there is a dilatation of LV, but it is not qualifying for the valve surgery, it should be followed more frequently. Mixed valvular lesion, they present very early, and then the single valve lesion. So these they become more symptomatic in a much faster way. So they will be subjected for echocardiography more frequently. So this is a commonly asked question: what will you prescribe? Initially, what will you prescribe? You will prescribe the benzathine penicillin. So what is the dose? Obviously 1.2 mega units. More than 30 kg, it is less than 6 lakh units in the less than 30 kg DP IMI injection every 3 weeks, because our country is an endemic country for the rheumatic virus. So we have to prescribe every 3 weeks. Why we prescribe every 3 weeks? We have to look for the literature that how the benzathine penicillin level falls after the 15 days, and it goes below the MIC after 3 weeks. So this is often asked question: what is the drawback of giving penicillin? So fatal reaction is the dreaded complication, and it is often when there is a single fatal reaction can derail the entire prevention program in a region. If patient develop a fatal reaction, then the whole of the hospital will be scared to deliver that benzathine penicillin prophylaxis. But remember, the most fatalities after the penicillin injection are not from the anaphylaxis. And anaphylaxis is very rare, 1 in 20,000 patients. It is very rare. And typically the fatality occurs in those who have advanced heart valve disease. And mostly it is supposed to be because of the severe vasovagal reaction rather than the anaphylaxis per se. And it is rare in the children and rare in those with the relatively mild disease. So remember, the patient who are having advanced heart disease, usually these patients develop because of the pain, because of the volume condition, they develop severe vasovagal reaction, and they may succumb to the condition, but it is a very rare condition. So a patient is not able to take injectable form, then what are the options? Should we prescribe these options? Penicillin V, that is Pentit, which is commonly used. Penicillin V is the Capen, is a 250 milligram. Sulfadiazine 1 gram, or macrolide and azithromycin or something. What is the duration? Duration is, we all know that patient of carditis who have a residual disease, they should be given at least 10 years or 40 years of age, whichever is longer. In India, a patient can take, then recommend for lifelong. A patient is not having any residual disease, 10 years or 21 years of age, whichever is longer. Rheumatoid fever without carditis, 5 years or until 20 years of age, whichever is longer. This is a standard definition recommendation. There are 2 preparations are available: penicillin V and penicillin G. Penicillin is a Pentit and penicillin V is a Capen. Capen is acid labile, and obviously if it is acid labile, you have to give in the empty stomach 1 hour before the meal or 2 hours after the meal. And the blood level is lower compared to the Pentit, which is a penicillin G. So there is a less individual variation. It is given in 250 milligram BD doses. But remember, all the studies have been performed with the penicillin V, that is a K-pen. And most of the time, what we prescribe is a penicillin G, that is a pentate. And there is no study comparing head-to-head versus penicillin G versus penicillin V. So disadvantage is that the compliance is a big issue because twice a daily, 365 days in a year is a difficult to take. And then it has been found in a US study that for the primary prophylaxis, 10 days therapy, it was less effective compared to the injectable form. It was observed that the 10 days therapy in an educated society of the USA of oral penicillin was less effective for the primary prevention compared to the injectable form. And it is less effective than sulfadizine, because we know that if you give patient is receiving benzathine penicillin, the recurrence rate is around 0.5 per patient year, whereas the recurrence rates with the oral sulfadizine is around 2.8 or 3, and with the oral penicillin it is around 5.5, almost 10 times higher compared to the benzathine penicillin. So always recommend benzathine penicillin injectable form. There was some few years back, there was some shortage of the benzathine penicillin. Some of the patients were switched toward the oral penicillin, but try to give benzathine penicillin. Never ever encourage the patient to take oral penicillin. Most of the time, these patients are insist on taking the oral medication, but try to convince that it is very difficult to continue the therapy for almost you can say that 365 days, twice a day is less likely. This is also a common question which is asked, is that when will you recommend for the coronary angiography? Patient is a known history of CAD, and subset, if you're suspecting myocardial ischemia in a patient having LV systolic dysfunction, which is out of proportion to the lesion, in men more than 40 years of age or a postmenopausal woman. This is the ESC recommendation of 2022. And if the patient is having, say, more cardiovascular risk, for example, diabetic or hypertensive again, and then subjecting this patient to the surgery. Coronary CT angiography is a reliable alternative. It's a class 2 indication in view of the patient who are with the low probability of CAD. You can subject this patient coronary CT instead of invasive angiography. CVG, when will you recommend the CVG? Because when the diameter loss stenosis is more than 70%, the patient is going valve surgery, then patient should get a graft when the stenosis is more than 70% in the proximal artery. It is the recommended. It's a class 1 indication, and the class 2 indication when there is a moderate stenosis, and PCI should be considered. It's a class 2 indication when the patient is going for the transcatheter aortic or mitral valve replacement. What about the AF? AF in a patient of regurgitant lesion, meaning by AS, AR, or MR. These patients should be getting anticoagulation therapy according to Chadwick's score. Patient of mitral regurgitation without having high Chadwick's score should not be getting any anticoagulation. So sometimes we have seen in the prescription the patient of mitral regurgitation getting anticoagulation. They should not be prescribed anticoagulation until they qualify for the anticoagulation according to Chadwick's score. And these NOAC is the preferred choice in those patients of aortic stenosis, AR or MR, whereas the NOAC is not recommended in a patient with moderate or severe mitral stenosis. Valve repair is being discussed. Obviously, it requires expertise, as only select center and a few of surgeons are doing, because it's a very long learning curve, and it has a very variable results, and durability is limited compared to the wall replacement. But obviously, it has a distinct advantage of avoiding the anticoagulation, and it is best suited to the pure mitral regurgitation with minimal fibrosis. Especially, you can say that a patient with mitral wall prolapsed with severe mitral regurgitation, they are the best candidate. In the rheumatic mitral regurgitation, if the cardi is not shortened, there is less valvular pathology, then these patients can be subject for wall repair. And occasionally aortic wall repair are also being tried. So regarding the indication of the surgery, well, just go by the this is the famous diagram by the study done by the Braunwald 235. The patient develops symptoms of heart failure. The median survival is 2 years. The patient patient of aortic stenosis develops syncope. The median survival is 3 years, and the patient develops angina. The survival is 235. This is a famous study done by the Braunwald. Intervention: if the patient is having symptomatic patient, severe aortic stenosis, should be subjected for the aortic wall intervention. It is recommended. It's class 1 indication. If the patient is symptomatic, severe, if the patient is having low flow, low gradient situation, or the patient is having preserved contractile reserve, then there's class 1 indication. If the patient is dilemma in the contractile region, the patient is having we have to confirm that the patient is having normal ejection fraction and there is a severe rotation is there, then this can be subjected for the aortic wall intervention, whether the TAVI or aortic wall replacement, and that is a different question. In asymptomatic patient, if the patient is having systolic LV dysfunction, asymptomatic patient, severe aortic stenosis, they should be subjected for aortic wall intervention. With the demonstrable symptoms on the exercise testing, then these relatively asymptomatic patient, if they develop symptoms on the exercise testing, they should be subjected to aortic wall intervention. And then if the patient is having less than 55 ejection fraction, means the ejection fraction start deteriorating, then it's a class 2A indication if the patient is asymptomatic, because likely these patients are going to have symptoms very soon. And the patient of very severe aortic stenosis, if the patient is not having symptoms and the patient is having very severe calcific aortic stenosis, there is a progression of the aortic stenosis of the patient is having high BNP level on repeated measurement. It's a relatively softer indication for aortic stenosis. So any symptomatic patient should be subjected for aortic wall intervention. Any patient with the decreasing AF should be subjected, or any patient undergoing CABG or other wall surgery with moderate to severe aortic stenosis should be getting aortic wall replacement. So medical management, obviously, there are few drugs which were tried. If the patient is symptomatic, just treat as any patient or other patient of heart failure with a diuretic. ACE or ARB or sideroxine is not being used. ACE inhibitor was tried in this trial. There was around 2,000 patients, and it was non-randomized observational study. It was just an observational study. What they have found that patients who are getting ACE inhibitor versus the placebo, they have a lower chances of aortic intervention and aortic wall. You can say the event rate. Other study which showed the Remifil 7.5 milligram BD in the mild to moderate aortic stenosis, what is the progression? It was almost similar. It was a negative study, and the statin was also tried in a patient of aortic stenosis. Keeping in mind that could be this could be related to the hyperlipidemia. Astronomer trial where the rosuvastatin was tried, it was a negative trial, and the SEAS trial, it was simvastatin plus ezetimibe trial, it was also negative trial. So statin has no role. Obviously, AS therapy, there's no medical therapy which had shown the improvement in the outcome or the change in the natural history. ACE inhibitor should be used when there is a patient having associated hypertension. If the patient is having symptoms, obviously these patients should be subjected for surgery because patient developing symptoms, especially the heart failure symptoms, they have a median survival only 2 years. So ACE inhibitor is a class 1 indication for patients who are having hypertension. It is a preferred drug over the other therapy. Beta blocker, it can be used if the patient is having associated coronary artery disease. Preload reducing drugs, a diuretic should be avoided because it can precipitate the symptoms. Regarding the aortic regurgitation, we'll just go the indication of the surgery. In the severe aortic regurgitation, what we recommend is the symptomatic patient, regardless of LV function. If the patient is asymptomatic, then if the LV and systolic dimension is more than 50 or index dimension is more than 25, then these patients should be subjected for surgery. Now, question arises, why should we consider this 50% or less more than 25 millimeter per meter square as the cutoff? Because if the patient is having more than 50 millimeter of end-systolic dimension, these patients are likely to have worse outcome because they have incipient heart failure, LV dysfunction. So in various studies, it was found that the 50 millimeter is the cutoff above which there is a incipient LV dysfunction. So these patients should be subjected for valve surgery. So in asymptomatic patient, if the index dimension is more than 20, lower than 25, and the LV ejection fraction is less than 55, it's just a class 2B indication, can be considered as a class 2B indication. A patient who's undergoing a CABG, if the patient is having a significant aortic regurgitation, they should be getting aortic valve replacement, or if the patient is getting a mitral valve surgery, and then the patient is having significant aortic regurgitation, they should be subject for the double valve replacement. So any symptoms at rest or exercise in a patient of aortic regurgitation or asymptomatic patient, if the ejection fraction drops below 50% or LV becomes dilated more than 50 millimeter and systolic dimension or more than 25 millimeter per square meter square, right? Medical management, basically the aim was to prevent the progression of disease. What we anticipate is the vasodilator therapy may help in reducing the afterload and they will improve the survival. The calcium channel blockers were tried. These were the initial few studies, few patients, and what way they have noted that nifedipine, they were given nifedipine. The 85% of the patient receiving nifedipine remained asymptomatic with a normal LV ejection compared to the 65% in the patient who are receiving, because initially the therapy was very limited. And this study was published in the NAGM way back in 1994. So it is our old study, initial study. Then the calcium channel blocker long-term therapy was tried, and what they have seen that neither nifedipine or enalapril reduces the development of symptoms or LV dysfunction in a patient warranted for AVR with placebo compared to the placebo. So they were not very effective drug. ACE inhibitor, 2,000 patients, what they have seen that the all-cause mortality and etc. was reduced. You can see the CV mortality events, all-cause mortality and aortic regurgitation events were reduced with the patient who were receiving ACE inhibitor in a patient of aortic regurgitation. Beta blocker therapy, calcium channel blocker was out, ACE inhibitor was some evidence regarding beta blocker therapy. It was a smaller study, but they have found that there was some difference patient receiving beta blocker compared to the no beta blocker in a patient of chronic aortic regurgitation, and it was irrespective of whether the patient was having coronary artery disease or not, no coronary artery disease. Patient of acute aortic regurgitation, it is an emergency, they require early surgery. And obviously patient is, when the patient is being prepared, you have to support the patient. Afterload reducing by the anatomocyte is often used. IABP, obviously, it is strongly contraindicated. And the beta blocker, if you are using in the patient with the aortic dissection with the aortic regurgitation, you have to be very cautious because beta blocker increases the diastolic time and it increases the regurgitation. Mitral regurgitation, I'll just indicate regarding the severe mitral regurgitation, aortic valve, mitral valve repair is recommended when the repair is recommended when you expect the results are durable and expected. And the symptomatic patient should be getting mitral valve replacement, and surgery is recommended in a patient with LV dysfunction, LV and systolic dimension more than 40. So here the cutoff is lesser LV dimension and ejection fraction less than 60%. Less, you can see that compared to 50%, it is more. And the LV dimension is less. Then we are subjecting this patient to surgery because in mitral regurgitation, LV is regurgitation is there in the low pressure chamber. So there is a you can say the falsely high ejection fraction in a patient of mitral regurgitation. In the aortic regurgitation, the trans-aortic gradient is more compared to the LV and aorta gradient. So there the dilatation is more. So LV ejection fraction is not falsely high. So the cutoff is less than 60% in the mitral regurgitation, whereas the less than 50% in the aortic regurgitation. So similarly, the dimension is lesser where we subject this patient for the mitral valve intervention because above 40 millimeter, or you can say the about 23 or 24 millimeter index, there is an incipient LV dysfunction. So simplified, any symptomatic patient or asymptomatic patient is the ejection fraction less than 50%, 60%, or new onset atrial fibrillation or pulmonary hypertension. We already discussed. We'll just skip these slides. Medical therapy, asymptomatic chronic severe MR. In asymptomatic severe MR, the ACE inhibitor at 6 months resulted in the significant reduction in the LV volume because these are the smaller studies. And in the other study, the patient who are having systolic blood pressure more than 140 had a decrease in the MR severity with the ramipril, whereas they don't have any change in the mitral regurgitation and the functional cardiac 6 months. Only the patient who are having systolic blood pressure more than 140, they have had some benefit. Beta blockers, it does have some benefit in the patient management or medical management of mitral regurgitation. They have been shown to be some effect on the management of the mitral regurgitation, medical management of mitral regurgitation. So medical therapy was the systolic dysfunction. We should be managing any patient of LV dysfunction, meaning by diuretic, ACE inhibitor, etc., etc. If the patient is not having LV dysfunction, so beta blocker may be tried. Acute mitral regurgitation is an emergency condition. Remember, in the acute mitral regurgitation, patient usually presents with the low cardiac output state. For example, in mitral valve dilatation, patient develop severe mitral regurgitation. Patient usually developed low cardiac output state. They present with a cold, clammy skin. They don't present with the pulmonary venous hypertension. They don't present with the pulmonary edema. They have a low cardiac output state. So here the vasodilator therapy is beneficial. So in mitral stenosis, we all know about this. This is often asked, what is the contraindication of the PTMC? So ACC or ESC take the criteria of more than 1.5 centimeter square as the severity of severe mitral stenosis. Less than 1.5, they take as the severe. So if the patient is having more than 1.5 centimeter square, there is a contraindication. LA thrombus, more than mild mitral regurgitation, severe or bicommissural calcification, absence of commissural fusion, and severe concomitant aortic valve disease or severe combined tricuspid valve stenosis regurgitation. Remember, the if patient is having moderate aortic valve stenosis and you are going to dilate mitral valve, be careful, because mitral stenosis, they decrease the gradient of aortic valve because the decreased LV filling. And God forbid, if this patient developed mitral regurgitation, then there is an obstruction in the LVOT and patient gets regurgitation in the LA. So these patients behave very badly, and the combination of AS with MR is a deadly combination. So medical management of mitral stenosis: if the patient develops heart failure, we manage as any patient of heart failure. Rheumatic fever prophylaxis should be given because mitral stenosis is always rheumatic in origin. Management of atrial fibrillation, or atrial fibrillation, we have to manage the heart rate and the anticoagulation. Anticoagulation indication, we have to give the vitamin K antagonist. There is no role of NOAC. Patient is having atrial fibrillation, whether it is a paroxysmal, persistent, or permanent. Remember, paroxysmal atrial fibrillation should be getting NOAC. And MS with the prior embolic episode, or MS with any evidence of left atrial appendage or left atrial thrombus, they all should be getting anticoagulation. We have to target INR between 2 and 3. And we already discussed that NOAC should be avoided, should not be given. And recently published Invictus trial has also suggested that rivaroxaban ban is not better than the VKA. So heart rate control is beneficial when the patient develops atrial fibrillation and patient is having fast ventricular response, and then the patient is having normal sinus rhythm, and a patient develops symptoms during exercise. What happens when there is a increase in the heart rate? Diastolic filling time decreases more compared to the systolic filling time, systole. So there is already stenosis, there is a less chances of filling, patient become more symptomatic. So how to evaluate the moderate valvular heart disease? See, we assume that the moderate disease do not cause symptoms. If you suspect the patient is having symptoms, then look for the other causes. For example, coronary disease and a moderate aortic stenosis for cause of the dyspnea. And we can subject these patients for exercise testing to assess the functional status. And exercise echo, it is especially useful in the patient of mitral stenosis. If the patient hemodynamic response of exercise, for example, the patient develops moderate or severe mitral signs of meaning by increase of the right ventricular systolic pressure as measured by the tricuspid regurgitation velocity after the exercise exceeded more than 50, then these patients are likely to be benefited by the intervention. If there is a suboptimal window, then cardiac MRI can be used, on the cardiac CT if there is a heavy calcification in aortic stenosis. If not, then cardiac catheterization should be considered. So we already discussed about the exercise testing, where should be getting, and we have to see the response of the blood pressure. We have to look for the symptoms. We have to monitor for the appearance of the pulmonary venous hypertension in the form of the vessel cramps, etc. And we have to again assess the hemodynamic response after the exercise by echocardiography, and what is the response of the right ventricular systolic pressure, what is the response on the gradient, etc. That has to be done during the exercise. So that's all for the presentation. I think this will be helpful for the preparation of Viva after the case presentation. If any question, then we can discuss.
Good presentation, boss. It will be helpful to every student to how to prescribe, approach the each valvular disease, even in the combine also.
Yeah, yeah. So any input from you regarding the case discussion presentation? Your points of regarding the history taking, etc., were very important, very good, and they should be remembered by every students. How to present with the history, how to analyze the history. That was very good.
Yes, now also the important is other than the exam is a clinical practice.
Yeah.
So whenever, as you have mentioned in the last few slides, that even moderately it is important. Why we try to avoid the subject the patient when it moderate disease category. We don't send subject. So whether patient really in moderate, only the clinical judgment, echo, EC, all will help to gather the evidence that no, definitely is moderate. So we can confidently make the patient on a medical therapy till the patient significant develop symptoms or the disease severity progress.
I think there is no question from the delegate. Then we can wind up the session. And is there any question from the delegate? Tech team, can you tell us? I don't think they have any questions. I think we should thank Dr. Dayasagar Rao and Dr. Devavit Roy for giving us the opportunity, and especially to the SCPGI to present a case. And my special thanks to my friend Dr. Anand Shukla to be my moderator, co-moderator. A very close friend of mine.
It is my privilege, sir.
Right. So I think we all be remembering the good old days of our case presentation. Right. Thank you very much.
Thank you very much. Yeah.
In case of any question, you can come to us anytime. Thank you very much.
Thank you very much. Thank you.
We are just leaving that.
Yeah.
All right. Thank you.